So without further ado, we'll jump right in. The following are my disclosures. So we'll start off with the case. This is actually a case that we had pretty recently, about a year and a half ago. It was a very interesting one, and I think covers some, essential topics pertinent to the management of EV ECMO. So the case starts off with a 56-year-old male who presented with some fever, cough, shortness of breath, and diarrhea for about a week. He presented to the emergency department and was promptly diagnosed with H1N1 influenza A. On clinical exam, they noticed that he was in some respiratory distress. He was saturating about 70 to 75% on ambient air. The emergency medicine docs quickly transitioned him to heated high flow and promptly transferred him to the medical ICU for further care. So as the case was reviewed, his past medical history was significant for hypertension and type 2 diabetes. His past surgical history is significant for an appendectomy about 3 decades prior. In his social history, he worked as a full-time construction worker, drank about 3 to 4 beers per week, and smoked e-cigarettes for the last 4 years. And this history was obtained from his wife. His functional status is he was fully functional at baseline, independent with all his ADLs, and like you said, was a full-time construction worker, so had no limitations at all. His vital signs in the emergency department right prior to transfer was he was febrile with a temp of 38.6. He was tachycardic with a heart rate in the 120s, and he was tachypnic with a respiratory rate in the mid-30s, and he was also normotensive on non-invasive blood pressure monitoring. The labs on admission as well were really significant only for leukocytosis with the white count of around 23. His BMP was unremarkable, LFTs were unremarkable, and other labs were also not significant. The chest x-ray on review in the emergency department showed some dense consolidation on the right with some opacifications in the left lower lobe as well, very much consistent with this clinical presentation of influenza pneumonitis. So for the first few days while he was in the medical ICU, he received oseltamivir therapy and was maintained around the clock on heated high flow. He's very limited, was bedridden for the 3 days that he was there, and with just oscillating oxygen requirements, and slowly, which were escalating day after day. By day 4, his hypoxemia had rapidly progressed, and given his sudden deterioration, the team decided to endotracheally intubate him and support him on invasive mechanical ventilation. They did also obtain a CT angio with PE protocol at the time. I think the rationale there was, they wanted to make sure that they weren't missing another diagnosis. They were going to send him to CT scan anyway. And, it ended up becoming positive for PE. But these are mostly subsegmental and segmental PEs in all the lung lobes. You can see here a CT scan. Again, there's diffuse ground glass opacities with really asymmetric distribution throughout the lung fields, consistent with his diagnosis of viral pneumonitis. So they did end up getting a transthoracic echo and ruled out any evidence of RV strain. His troponins and BMP were all within normal limits. He was promptly started on heparin infusion and ended up requiring very deep sedation and continuous paralytics as well. The team also very promptly started prone positioning trials and maintained him in the prone position for about 16 to 18 hours during the day and put him back on his back for a few hours for nursing care and respiratory care. What was also remarkable is that his clinical workup was significant for MSSA bacteremia. So they'd also actually promptly obtained a transesophageal echo, which ruled out any evidence of infective endocarditis. And soon after that, also his BAL culture was positive for MSSA as well. So by the end of the week, his ICU labs were significant really for this persistent leukocytosis. His platelet counts had dropped marginally. His, liver function test and kidney function tests were largely stable and unchanged. We noticed that on his radiograph as well, there was starting to appear a little bit more asymmetrical distribution of this bilateral opacities, very much consistent also with ARDS due to his underlying viral pneumonitis. So the first question that I have for the entire group is, which of the following therapies or interventions would have been shown to decrease mortality in patients with severe ARDS? Wonderful. So it looks like the vast majority of you have selected prone positioning. So when we actually review the data here, I think many of us are very aware of the ARMOR trial results, which show that low tidal volume ventilation was associated with a mortality benefit in patients with respiratory failure. And so essentially, these are tidal volumes in the range of 6 to 8 cc's per kg of ideal body weight. And this was in stark contrast to patients that were exposed to 10 to 12 cc's per kg of ideal body weight. Lung recruitment maneuvers as well. I think there's been a lot of observational data that's been, published in the literature. And if you look at the latest ARDS guidelines from both ESICM and ATS, they strongly recommend against any lung recruitment maneuvers. High-frequency oscillatory ventilation as well has been, there have been a couple of negative trials with OSCAR and Oscillate. And paralytics as well. I think the first trial that came out shows some, equivocal results through Accurasis, but the Rose trial, which was actually conducted outside here of Pittsburgh, was a negative trial and showed no mortality benefit with paralytics. So the correct answer here is prone positioning trials, where the ProSIFA trial showed that there was a clear mortality benefit in patients with severe ARDS. Excellent. We got, most of the audience got that question right. Perfect. So on day 7, after 3 days, he continued to be maintained in a paralyzed and prone position. His PF ratio at that point had been less than 80 for almost 12 hours. And to give you an idea, he was maintained on assist control, volume control ventilation, tidal volume of 500, which was just around 6 to 7 cc's per kg for him, with a respiratory rate around 26, FiO2 at 100%, and a PEEP of 16, with the plateau pressure around 35 or so. So at this point, the ECMO team was consulted, and here you can see that, throughout the course of, the day, that his PO2 continued to remain in, the mid-70s on 100% and 16 a PEEP. So essentially refractory hypoxemia. So day 7, these are, like we mentioned, these are his ventilator settings that I just reviewed. And on the left-hand side, you can also see his height, weight, BMI, and body surface area as well. So this way, it gives you an idea, right? This is a very tall gentleman, who weighs around 120 kilos and was obviously maximized on invasive mechanical ventilation support. So our second question is, which of the following would be a relative contraindication to VV ECMO in this patient? Remember, relative contraindication. Excellent. I think here we've got a, clear division between some of these, but we'll go over each of these factors, right? So e-cigarette use in and of itself, is not really a contraindication to VV ECMO support, right? I think if it was e-cigarette associated with, chronic respiratory failure or chronic obstructive pulmonary disease would be a different factor, right? Especially in somebody if they become home oxygen dependent as a result of chronic cigarette use, which in this patient, we said he was only been smoking for 4 years prior, so would not be a relative contraindication. Second would be his alcohol use. Like we said, it was only about 3 to 4 beers per week. So unlikely that, that amount of drinking would have led to any significant chronic liver disease as well in this patient. And as we noticed, his liver function tests were all normal. So it looks like, we've got about 20% of the participants that selected acute PE. Acute PE, especially without any evidence of RV strain, and like we said, the clots were all segmental or subsegmental. So not hemodynamically significant, did not result in any RV strain. So in and of itself would not be a contraindication to VV ECMO support, right? These patients, if we were considering respiratory ECMO support, would be able to, be supported on ECMO and be anticoagulated for the PE and would not require any further therapy. Bacteremia, a good 20% of you selected this. So this would probably be a trick question even for myself. If we took this, if we were kind of going over the consult, the one thing that would probably be of most concern to me would be somebody with persistent bacteremia. So we're talking about high-grade bacteremia despite antibiotic therapy and or source control. So this would be a situation if you were to cannulate the patient that, and they had persistent high-grade bacteremia, that clearance of this bacteremia would be very challenging on ECMO and, may present itself to be a relative contraindication if it was persistent or high-grade. But in this patient, we clearly see it's a primary pulmonary infection and, the bacteremia that resulted was being appropriately treated with antibiotics and was not a point of concern for us. So there's nothing here between all these factors that are considered relative contraindications, and hence the answer is none of the above. Thank you. Perfect. So on day 12, the case review was completed by the ECMO team. We clearly elucidated a reversible cause of the patient's respiratory failure, right? It's a viral pneumonitis with a bacterial superinfection. On reviewing his case, the patient had single organ failure and met our inclusion criteria based on the PF ratio and the duration that the PF ratio was less than 80. And this is despite optimal conventional medical management as well. There were no exclusionary criteria like we just reviewed in the previous question. And so our team decided to proceed with VV ECMO cannulation. So here you can see some patient factors on the left side. And our third question comes up based on this information that you have here. What size cannula would you select for a FEM-IJ configuration in this patient? So remember, he's around 6'4", and he's about 120 kgs. And you can see the diameter of his common femoral vein is about 10 millimeters on ultrasound, and the diameter of his right IJ vein is around 8 millimeters on ultrasound. Excellent. So it looks like, more than 50% of you selected a 27 drain and a 21 return. Now, I think when we're, reviewing the, cannulation strategy specifically here, what's super important is going to be what is the underlying diagnosis, how much flow is the patient going to require, and how large are the cannulas that we can insert based on the patient's anatomy, right? So we know he's 6'4" and 120 kgs and probably has a very high cardiac output as a result of his viral pneumonitis and bacterial superinfection. So he's going to have high flow requirements. So you want to be able to put in the largest cannulas that the vessels can accommodate. So when we're looking at the common femoral vein diameter of 10 millimeters, so the circumference of the common femoral vein is going to be 10 into pi. So around 30 French, right? So a 27 French drainage cannula would easily be accommodated into a 30 millimeter common femoral vein, allowing for flow around the cannula as well to prevent complete stasis. Similarly, in the right IJ with the diameter around 8 millimeters multiplied by pi, that gives you around 24 millimeters in diameter in circumference. So that gives you, right, an easy access to be able to insert a 21 French return, right? So if we're using very small cannulas like a 23 drain and a 15 return, right, we're only going to be able to flow, somewhere between 3 liters or so, and we're going to be limited. But this patient clearly we know needs a large drain, so at least a 27 drain. But if you insert a large drain with a very small return, like an option 2, right, we know that there's going to be this phenomenon of return obstruction, right? The flow downstream of the ECMO pump is the resistance upstream of the ECMO pump is going to be very high because the cannula is small. So what you want to do in almost every instance, if the patient has high flow requirements, a large drain and a large return should be able to accommodate the flow requirements that a patient like this would need. Excellent. All right, so we'll move back to the case. So the cannulation strategy that we employed in this patient was we inserted a 27 French multi-stage venous drainage cannula into the right common femoral vein and a 21 French right IJ vein return cannula as well. By ECMO day 4, we noticed that it was, progression of his lung injury and lung disease with dense consolidation bilaterally, right greater than left, with what appears to be maybe a small pleural effusion on the right side. And we can see the tips of the drainage and return cannula are spaced about 9 centimeters apart from each other, which is appropriate, had very minimal recirculation as well with the locations of these cannulas. So on day 4, we noticed that he had a bronch done a couple of days prior to that, and now the BAL culture started to grow ESBL Klebsiella in addition to the pre-existing MSSA infection that he had. And we also noticed that his temperature on ECMO support was around 36.2, but now, we noticed that the patient had developed progressive septic shock with escalating norepinephrine and vasopressin requirements as well, the doses of which are shared here. And we could see that, again, he had persistent lupus. His LFTs and kidney function tests were all within normal limits, even at this time. So the rounding team decided to do a point-of-care ultrasound, especially with the escalating oxygen requirements, to ensure that the patient did not have any cardiac dysfunction. And the point-of-care ultrasound promptly showed that the patient had preserved biventricular function. His ventilator settings at that time are shown here. He was set on pressure control with a delta pressure of 10, a rate of 10, an FiO2 of 40%, and a PEEP of 15. And with those settings, he was generating about 275 cc's of tidal volume. He continued to remain sedated and paralyzed, and the rounding team at that time continued to maintain prone positioning trials as per their recommendations at the time. Fiber optic bronchoscopy was also performed earlier in the day for secretion clearance, and some mucus plugs were suctioned out, and otherwise the airways were relatively clear. And based on the X-ray findings that I showed you previously, a point-of-care ultrasound was done as well along the lung lines, and there was no evidence of pleural effusions on either side. And it turns out that it was just dense consolidation bilaterally. So here we can see his ECMO settings. He's set at 6 liters of sweep gas flow, 100% FDO2, flowing about 6.5 liters at 4,700 RPMs with the drainage pressure of just over 100 millimeters of mercury and with an SVO2 of around 70. So it looks like minimal recirculation. His drainage pressures are a little bit on the higher side, and we can see his flows also are close to the rated flow of the oxygenator as well. Unfortunately for this patient, what we start to notice is despite optimal medical management and maximum ECMO support, and you can see his PO2s going from right to left on your screen, continue to decrease. His nadir PO2 was around 45 millimeters of mercury around 6:30 in the evening. At the same time, a post-oxygenator blood gas was obtained, and you can see that on the left, with an exit PO2 of around 380. What was most concerning for us as we were managing him was, even though he was becoming progressively more hypoxemic, we started to notice that his lactate continued to trend upwards. And this was extremely concerning because we knew that he was starting to develop progressive tissue hypoxia. So in this specific situation, it's always good to develop a differential diagnosis of what is causing hypoxemia in your patient, and then narrowing in on that diagnosis, and then seeing what you can do to help modify the driver of the patient's hypoxemia. So a nice way of looking at it is utilizing this equation that's been detailed here. You can see that the arterial oxygen saturation is actually a combination of the highly oxygenated ECMO flow that's present in the red box. So you can see that's a product of your effective flow over your cardiac output multiplied by the oxygen saturation at the outlet of your membrane lung. And also because there's venous admixture that occurs in the right atrium, this highly oxygenated blood from the ECMO circuit combines with the deoxygenated blood as part of your venous return that's shown in blue. So the combination of these, if there is no intrinsic native lung function and there's no step up at the level of the native lungs, the PA saturation is going to be equal to your arterial oxygen saturation. So if you run through the causes of each of these variables being altered, it will really help you narrow down what the cause of hypoxemia is. So if we're looking at the first variable, which is your effective ECMO blood flow, right? If effective ECMO blood flow decreases, your arterial oxygen saturation decreases, right? So our next question is, which of the following is not a cause of decreased effective flow? Excellent. So about 2/3 of the participants selected fever, which is the right answer. So remember, drainage insufficiency, recirculation, and insufficient ECMO flow all result in decreased effective flow, right? With drainage insufficiency, since there isn't highly oxygenated blood being returned to the right atrium and being provided to systemic circulation, it results in decreased effective flow. If there's recirculation, all the highly oxygenated blood is being taken up by your drainage cannula, and you have what we call wasted flow that essentially does not contribute to the arterial oxygen saturation. And with insufficient ECMO flow, that's essentially low RPMs generating low flows, right? Since you're not maximizing exposure of the membrane lung to the maximum amount of, the rated flow, that situation where what you have is decreased effective flow, right? So always remember, decreased effective flow, right? The differentials for that is drainage insufficiency, recirculation, and insufficient ECMO flow, right? Fever in and of itself should have no impact on ECMO blood flow. Excellent. All right. So we talked about the 3 causes of decreased ECMO flow. So the next variable that we look at is a increase in cardiac output that results in hypoxemia, right? So which of the following is not a cause of increased cardiac output? Excellent. So we have 3/4 of the participants selected recirculation. So we know sepsis is a high output state, right? In certain circumstances, obviously there could be uni or biventricular dysfunction associated with sepsis, but sepsis without myocardial dysfunction, right, is a high output state. And fever as well, right? Because there's increased metabolic demand, what ends up resulting is, the body augments cardiac output to counteract the effects of increased metabolic requirements. And the same with agitation, right? When patients are agitated, they have their increased in sympathetic tone, and the increase in sympathetic tone augments your cardiac output as well. Fever, sepsis, and agitation are causes of increased cardiac output. Recirculation, on the other hand, has no impact at all on native cardiac output. Excellent. All right. So the next variable that we need to look at is the membrane lung oxygen saturation. So this is the oxygen saturation at the outlet of your membrane lung, right? So if there's a decrease in your membrane lung oxygen saturation, you result in hypoxemia. So our next question is, which of the following is not a cause of decreased membrane lung oxygen saturation? Excellent. So it looks like about 2/3 of the participants got the answer correct with cardiogenic shock. So membrane lung failure, right? So if the membrane lung fails and gas transfer is impaired, right? O2 transfer is also impaired, right? So the membrane lung oxygen saturation is going to be low. In gas failure, which essentially means there's no sweep gas connected to your oxygenator, right? If there's no gas, right, there's essentially no ECMO and no O2 transfer occurring. Circumstance, right, it results in low membrane lung oxygen saturation. Low FDO2, right, so a lower fraction of delivered oxygen to your membrane lung will result in a decreased membrane lung O2 sat. And the same for high ECMO blood flow. So if the blood moves past the rated flow of the oxygenator, right, there is limited time for gas transfer to occur. So paradoxically, when the ECMO blood flow exceeds the rated flow of the oxygenator, there is less efficient gas transfer occurring and the membrane lung oxygen saturation decreases. So 4 of those factors decrease your membrane lung oxygen saturation, and cardiac dysfunction or cardiogenic shock has no effect on your membrane lung function at all. Excellent. All right. And finally, a decrease in SVO2 can result in hypoxemia. So our next question is, which of the following is not a cause of decreased SVO2? So about 50% of the participants got that right. If we're looking at the central venous oxygen saturation, essentially it's a reflection of tissue oxygen consumption and is a surrogate for cardiac output. So when the patient has cardiogenic shock and a low flow state, right, tissue oxygen extraction increases, and as a result, the patient has a decreased central venous oxygen saturation. The same thing with anemic patients, right? Oxygen extraction increases and SVO2 decreases. And in patients that are febrile, right, because of their higher metabolic demands, right, there's more oxygen extraction occurring and hence a decrease in the central venous oxygen saturation. So these 3 factors all decrease the SVO2. The increased ECMO blood flow actually has no impact on the SVO2. Excellent. So our next question is, based on our review of hypoxemia on VV ECMO, what is the cause of refractory hypoxemia in our patient? Right? So we've reviewed each of these factors. All right. So I think this is a challenging question. It looks like we've got a split on all answers, but let's go through each of these individually, right? So decreased effective ECMO flow, right? So we said the causes of that is drainage insufficiency, which our patient does not have, recirculation, right? When we looked at the cardio help module, we saw that the pre-oxygenator saturation was around 60 to 70%, so no recirculation. And also decreased effective flow. But our patient, we were flowing about 6.5 liters, close to the rated flow. So low ECMO flow was not a cause, right? So decreased ECMO flow is not the answer. What about decreased membrane lung oxygen saturation? So we said the causes of that are membrane lung failure, right? We assessed gas transfer across the membrane lung and saw the exit PO2 was almost 380, right? Gas failure, right? Also not the case in our patient because obviously there was gas transfer occurring across the membrane lung. Our FDO2 we had set at 100%, and we were flowing under the rated flow of the oxygenator, which in most commercially available, and including the cardio help, is around 7 liters. We were flowing around 6.5 liters. So it's not decreased membrane lung oxygen saturation. What about decreased SVO2, right? So we noticed that our patient's hemoglobin was around 12, so it was not severely anemic. They had done a point of care ultrasound and showed preserved biventricular function, so it's not cardiogenic shock. And we noticed that despite being on ECMO, the patient's blood temperature was relatively stable at around 36.2. So what that leaves at the end is increased native cardiac output, right? So we know this patient has a viral pneumonitis and now has developed a secondary superinfection with the ESBL Klebsiella that we noticed, right? And now with the superinfection and preserved cardiac function, right, the resultant hypoxemia has caused tissue hypoxia and a increase in the patient's native cardiac output. So as we go through each of these answers, it's also very important for us to understand few key physiologic concepts. So in this very elegant study by Mathieu Schmidt and his colleagues at La Pitié in Paris, they noticed that for ARDS patients that were supported on VV ECMO, an ECMO flow to cardiac output ratio greater than 60% always ensured that the oxygen or the arterial oxygen saturation would always be greater than 90%. So whenever you're clinically supporting patients with ARDS on ECMO, you always want to ensure that your ECMO flow to cardiac output ratio is greater than 60%. So the problem that we have here in our patient is that the native cardiac output has increased as a result of the superinfection and has now resulted in tissue hypoxia and anaerobic metabolism. How did we detect this? This is by the trend in lactate that we saw, right? We noticed that as the patient became progressively more hypoxemic as a result of tissue hypoxia, right? Anaerobic metabolism ensued and lactate generation was increasing over time. So the solution really here is fixing your ECMO blood flow to cardiac output ratio, right? And ensuring that it is greater than 60%. So it leads to our next question is how can we treat this problem in this patient? How do we correct refractory hypoxemia in this patient? All right, so it looks like, we have a split between two answers, but let's go through each of these options together, right? So the first is beta blockers to decrease cardiac output, right? It's very important for us to understand the effects of using negative inotropes or chronotropes in patients in VV ECMO to help decrease cardiac output. So again, Mathieu Schmidt performed a really elegant experiment on patients on VV ECMO and noticed that when beta blockers were utilized in patients with refractory hypoxemia, what they noticed was even though there was a decrease in native cardiac output, as you would expect with beta blocker use, there was a concomitant increase in arterial oxygen saturation. But what's most important here, and the take-home message should be that what they noticed was the tissue oxygen delivery on the other hand decreased across all patients. And this is very important physiologically. So when we look at each of these three different scenarios, right? The first scenario is a patient on VV ECMO who's flowing about 4 liters on ECMO, right? And has a native cardiac output of around 5 liters per minute, right? So this results in a ECMO to cardiac output ratio of around 80%. The arterial oxygen saturation in this specific patient would be 100%, and your tissue oxygen delivery is maintained at around 500 cc's per minute. But when there's increased oxygen demand and the native cardiac output increases, you can see your ECMO to cardiac output ratio decreases to 40%. In turn, your arterial oxygen saturation also drops to 85%, but there is tissue oxygen delivery is maintained, right? And this is maintained by augmenting cardiac output. However, when you utilize beta blockers and decrease their native cardiac output, even though your ECMO to cardiac output ratio is improved and your arterial oxygen saturation is improved, here you see the most important effect of utilizing beta blockers is there is a marked decrease in overall tissue oxygen delivery, right? Which can be detrimental for patients because remember, right? Optimizing tissue oxygen delivery is the ultimate aim of VV ECMO, right? It's not to correct arterial oxygen saturations or partial pressure of arterial oxygen either, right? It's to augment tissue oxygen delivery. So overall, the effect of beta blockers is it intrinsically lowers native cardiac output, but it increases your ECMO blood flow to cardiac output ratio. It increases the arterial oxygen saturation, but most importantly, it decreases overall tissue oxygen delivery. So our next option is adding a membrane lung either in series or parallel. You know, some people may try this, right? And the question is really what effect does adding another membrane lung have in gas transfer for patients? So here in this in silico experiment, looking at single and dual oxygenators, you can see whether they were placed in series in figure A or they were placed in parallel in figure B, right? There's very little change in the amount of oxygen transfer that's occurring, right? And if anything, physiologically, what you may see is going to be a increased in resistance without any added benefit of increased oxygen transfer. So adding a membrane lung in series or parallel is unlikely to have a strong clinical benefit in correcting tissue hypoxemia. So the third option that we have is converting the patient to a hybrid high-flow VV-V ECMO by adding a additional drainage cannula. So if we look here, this patient who has a 27 drain and 21 return is flowing close to 6.5 liters at 4,700 RPMs with a negative drainage pressure of just over 100 millimeters of mercury with minimal amounts of recirculation with an SVO2 of 70. So what does this really tell you, right? The concept here that we have to review is going to be the concept of rated flow. And a way to think of rated flow clinically is it is the maximum blood flow that a oxygenator will accommodate to be able to efficiently transfer oxygen at 100% efficiency. So if you're looking at the first figure on top, right, you can see your blood flow path is from left to right. If the blood flow is less than the rated flow of the oxygenator, you can see that you have saturation occurring in the very early parts of the blood flow path. So essentially, you have a large portion of your oxygenator that is not transferring oxygen. When your blood flow equals the rated flow of the oxygenator, here you can see that there is maximum gas transfer occurring with full utilization of the efficiency of the membrane lung. However, when the blood flow exceeds the rated flow, as we had mentioned before, there's less transit time for gas transfer to occur efficiently. So paradoxically, what happens when you exceed the rated flow of the oxygenator is that the gas transfer decreases. So in our patient, what we noticed was, right, that the patient was flowing close to their rated flow. So adding a additional drainage cannula, right, if you were able to flow 2 or 3 liters in excess, flowing 8 or 9 liters in total is not going to be helpful because you will exceed the rated flow of the oxygenator, right? And for almost all commercially available oxygenators, the rated flow is around 7 liters per minute. So flowing in excess of that is not going to improve gas transfer, right? So adding a additional drainage cannula in this patient would not be helpful. So finally, that leaves us with adding a parallel ECMO circuit, right? And physiologically, we'll review what this is able to do for the patient. So we took this patient to the Flora suite and I cannulated the contralateral side of the patient, put in a 23 French drainage cannula in the left common femoral, and added a 19 French left subclavian return cannula. So here you can see the fluoroscopic images of both return cannulas, right, terminating in the superior cavoatrial junction. So here, when you're looking at both the consoles, right, you can see that separately we're flowing 5 liters in one circuit, 3 liters in the other. Our drainage pressures have decreased, right, from what was around minus 110 millimeters of mercury that come down to the mid 60s and mid 70s. Our SpO2s are acceptable, and we're utilizing about 4 liters of sweep gas flow in each circuit, right? So question is, at this level of support, how did this impact patient's gas transfer and hypoxemia that we had observed prior? So we can see here, again, moving from right to left. So around 7 p.m. after institution of the dual circuit, you can see our PO2 went from 52 to 81 below, and then plateaued somewhere around 70 millimeters of mercury, right? So jumped up around 20 points or so. Concomitantly, you can see what's happening to the lactate, right? So as soon as you've corrected the hypoxemia, right, your DO2-VO2 ratio is restored, and you can see that the tissues move from anaerobic metabolism to aerobic metabolism, and you see a clearance in lactate. So this may be hard to see through the screen, but here you can see all 4 cannulas. You can see the return cannulas up in red, both of the drainage cannulas down there in blue. They were all appropriately positioned and with minimal recirculation. So the patient's continued ICU course was very complicated. He actually developed necrotizing pneumonia, and as a result of that, suffered pulmonary hemorrhage and required a bronchial artery embolization, and had to return to the IR suite a couple of times to get those embolizations completed, and unfortunately had progressive decline over the course of the next week, where he developed abdominal compartment syndrome, which required percutaneous decompression at the bedside. Few days later, went into oligoanuric renal failure, requiring kidney replacement therapy. And here you can see the CT at the time clearly shows that he's developed necrotizing pneumonia, with the cavitary lesion noted on the right side of the lung, with dense consolidation on the right. And over the course of the next few days, unfortunately, we start to notice that there were more complications related to ECMO. He suffered oropharyngeal bleeding that was refractory despite holding anticoagulation, which had continued. ENT had evaluated at the time and tried to achieve hemostasis with topical therapies, but the bleeding continued. He also developed a right pneumothorax, which would be expected considering that he had that subpleural cavitary lesion, and promptly had a pigtail catheter placed, but unfortunately continued to deteriorate over the course of the next few days and promptly developed multi-organ system failure. And after discussions with his family, the decision was made to transition to comfort measures, and he had unfortunately passed away soon after. So this case really helps to highlight a algorithmic approach to refractory hypoxemia on VV ECMO. And once you use that algorithmic approach to narrow down the primary cause of hypoxemia, it really helps to correct that cause and correct the abnormalities that you have and improve overall tissue oxygen delivery. So I think this is, that slide, especially that delineates each of the differentials, is extremely helpful. And with that, I'd like to conclude my presentation and would love to take some questions from the audience if there are any.
What an effort and outstanding care that you provided for this unfortunate patient. And this is just a fact of life. We cannot save them all, and we just have to do what we have to do. And the outcome is somehow decided by a force, or, you know what I mean. We have got a few questions from the audience, and the first question comes from one of our colleagues who's asking about the HIV status of this patient, who's asking into initiating or providing ECMO support or ECLS support in your center, Raj.
Yeah, so our specific center, HIV AIDS is not an absolute contraindication. So usually for these patients, we'll check CD4 subsets and check overall viral loads. And based on that, if they've got opportunistic infections in a patient with uncontrolled HIV or AIDS, that would probably be a relative contraindication for our program. But the vast majority of HIV/AIDS patients that we do see here are actually well controlled with the antiretroviral therapy as outpatients. So if they came in with no significant viral loads and preserved CD4 subsets, we would definitely assess their candidacy for ECMO. So it's not an absolute contraindication here. And I think there's a lot of emerging literature as well from the ELSO registry that
Yeah.
shows that, there's actually, depending on, careful patient selection, that there's an opportunity to see success in this patient population.
Yeah, absolutely. I think there is more encouraging data coming from the ELSO registry and elsewhere in the world that HIV is not an absolute contraindication and it should be case by case on MDT discussion, etc., etc. How about steroids in this particular patient? Has it been considered or given at any given time during the course of the management?
Yeah, I think that's a great question. I think, there's been a lot of equivocal data on the use of steroids specifically in CAP and even with that around ARDS. I can tell you, our institutional experience, considering, we do about 150 ECMOs a year, we've actually seen patients that come with viral pneumonitis that have these super infections, exposure to steroids in this patient population. We've actually seen a very strong signal for fungal super infections in these patients. So when there isn't strong supporting evidence for the utilization of steroids in ARDS, my personal practice is to avoid them, to avoid the potential complications associated with it when we know that there isn't, a detailed and significant benefit associated with steroid use in ARDS or pneumonia.
Okay. There is a question about mechanical thrombectomy and the role of, has PE or this has been considered as a contributing factor or mechanical thrombectomy in this persistent hypoxemia? Has this been discussed during the rounding mornings, etc.?
Yeah, that's a great question. I think the role or utility for mechanical thrombectomy, again, depending on how you want to risk stratify a patient with PE. Remember, when we looked at this patient, only had segmental and subsegmental PEs
Yeah.
with no RV strain. So there was no central thrombus burden and there was no concomitant RV strain. If you were to risk stratify this patient, right, this would be low risk PE. So there's no role in mechanical thrombectomy. But for patients, obviously, at intermediate or high risk or patients with catastrophic PEs, there would definitely be a role based on the anatomic location of the thrombus to utilize mechanical thrombectomy. And if this patient did present and we noticed that there was a saddle embolism and or there was, high risk features with, elevated lactate or tachycardia or RV strain, any of those things would have actually prompted us to take the patient to the cath lab first and do the mechanical thrombectomy and then assess candidacy before moving directly to ECMO support. So absolutely, there is a role for mechanical thrombectomy, but it has to be obviously based on the risk factors of the PE and the anatomical distribution of the PE as well.
One
Great.
final question before we move to the second speaker for the evening. The moment of conversion from single organ failure or not a single, from pure respiratory to multi-organ failure and septic shock with MOF, VA as an ACLS, has it been thought of, considered, or does it have a rule, or what's your take on that?
Yeah, I think, again, the data on this is equivocal, right? I think the Mathieu's group and Alain's group in Paris probably have the largest experience, I think, of supporting septic cardiomyopathy patients with veno-arterial ECMO. In our specific patient, if you noticed, each of our point of care ultrasounds actually showed preserved biventricular function. What we would have actually encountered if we did decide to go peripheral VA ECMO on this patient and try and support them is you immediately would have developed differential oxygenation with regional hypoxemia, right? Because the patient had such intrinsic severe lung disease, but preserved cardiac function and would have had retrograde blood flow. So this paradoxically actually would have worsened tissue oxygen delivery and tissue hypoxemia. So I think here in this specific case, when there is preserved cardiac function and refractory hypoxemia, veno-arterial ECMO would not be the answer.
Yeah, I agree with that. So I think we have had a great audience this evening with 70 plus participants, and we have had such a fantastic talk. I really like that equation from Bishoy. I think he published that in Asayo last year when he talked about persistent hypoxia. That was a very good paper. And thank you so much. That the effort and the presentation was amazing. I learned a lot from you today, Raj. And thank you so much for being with us this evening. And we look forward to having you again on this course and other courses. So we just have to move on to the second presenter this evening, and we'll see if we have another opportunity to see you again. Thank you so much, and take care, my friend.
Thank you so much, Ahmed, and good luck to all the participants. Hope you continue to enjoy this wonderful course. Again, I'd like to thank Doctors Waleed, Hisham, and Ahmed, obviously yourself, for this kind invitation. Obviously look forward to connecting with everybody soon, and good luck to all the participants.
Most welcome. Thank you.
Thank you very much.
So thank you for this very kind introduction. I would like to thank the organizing committee for inviting me to speak. It's usually very difficult to speak after high-class experts. There's big shoes to fill, but bear with me until I get to the end. I will be talking about ECLS and acute RV dysfunction that is associated with ARDS. So I have no disclosures to give. In the presentation, we're going to talk about the etiology of RV dysfunction. We're going to then talk about incidence and mortality. We're going to circle back around RV rescue therapies. Then specifically, how does VV and VA ECMO affect and impact the RV and the RV physiology? We're going to talk about the role of MCS and different modalities of MCS. It will be a case base, and before starting, I would like to start with this question. Okay, so about 1/3 of you got the right answer. So let's talk about this question in details. As we know that the pulmonary vascular resistance, which is the PVR, gets significantly affected by 3 major factors, which is hypoxia, hypercapnia, and metabolic or respiratory acidosis. And so answer A and all not the correct answer. However, hyperoxia and alkalosis are the contributive factors that do not actually increase the PVR, and they're equivocal on it. Okay, so without further ado, let's start with a case. So we have a 55-year-old gentleman who was diagnosed with COVID-19 ARDS. After 6 days of conventional therapy and proning, he was also on neuromuscular blocking agent with rocuronium. He still had significantly borderline PF ratio. However, it was better than what he started. So his PF ratio at the beginning was in the 50s, 60s, 70s, but after a few days of managing him with proning, conventional therapy, and INO, his PF ratio became borderline at around 100, and that's why INO was discontinued at that stage. However, despite his lungs showing borderline improvement, he had a sudden deterioration in his hemodynamics over 1 day, specifically over 6 hours. His lactate started climbing up, his blood pressure became borderline, and he was started on vasopressors at the doses that are mentioned in front of you. So he was on 0.06 mics per kilogram per minute of norepinephrine, and he was then started on 2 units per hour of vasopressin. His peripheries were cool to touch, and point of care ultrasound at the bedside showed the following. So here we can notice that this patient obviously has significant RV dysfunction. And from the presentation title, we can notice that this patient has RV failure. And here we have RV dilatation that is noticed. And so let's talk about etiology of RV failure in ARDS. And so RV failure gets vascular alterations because the permeable membrane of the pulmonary vasculature gets leaky, and so this causes increase of the PVR. Hypoxia, on the other hand, does the same thing. Hypercapnia and effects of mechanical ventilation, because not all patients with ARDS can get lung protective ventilation. This significantly causes sometimes lung injurious ventilation. And so if we look into ARDS, it causes hypoxia, hypercapnia, edema, intrapulmonary shunting, and injurious mechanical ventilation. This all increases the intrapulmonary pressures, and this further increases the PVR, which causes RV dysfunction or RV impairment. And so, if we talk about the incidence, RV dysfunction in ARDS has been shown to be up to 25%. That tells us that a lot of our ARDS cases actually has unnoticed RV dysfunction. And if we look into patients with RV dysfunction who have severe ARDS, who are close to be candidates for VV ECMO, we can find that in those patients, up to 50% have been shown to have RV dysfunction or RV failure. And if we look into mortality, despite significant advances in medical advancements, ARDS still is associated with an unacceptably high mortality. And RV dysfunction is well documented as an important risk factor that increases mortality. And that's why we have to talk about RV dysfunction and how we tackle it. So overall mortality in RV dysfunction is mortality of ARDS is 30 to 40%. However, when we add RV dysfunction, the odds ratio of that increases by around 1.7 for general ARDS and about 3 for COVID-19 ARDS. And when we look into the specific phenotype of cardiogenic failure, of RV failure, we find that it increases mortality by around 78%. This is why it's extremely important to talk about. What are the RV rescue therapies that have been used to help rescue that RV, to prevent that RV from going into the spiral of death? And as you all know, treat the underlying causes of hypoxia, hypercapnia, acidosis, optimize your preload, decrease the PVR by either milrinone, inhaled nitric oxide, or inhaled Flolan, which is used in multiple institutes. Increase your systemic vascular resistance via selective vasopressors to make sure that your SVR-PVR ratio is in favor of your SVR, and prone position if RV failure is associated with ARDS. Now, if all of this fail, obviously ECLS is considered. And when we talk about ECLS, we have to talk about how does VV ECMO impact our RV, and how does VA ECMO impact our RV? Because both of them have different impact physiologically on the right ventricle. So we know that any type of ECLS reverses hypoxia, and it reverses hypercapnia, which in terms reverses our respiratory acidosis. It enables ultra-protective lung mechanical ventilation, which will help with mechanical prevention of increase in our pulmonary vascular resistance. And so when we have a patient with ARDS and severe RV dysfunction who is put on VV ECMO, this VV ECMO, as we mentioned, reverses the hypoxemia, hypercapnia, respiratory acidosis, and enables ultra-protective lung ventilation, which all of these contribute to decreasing our pulmonary vascular resistance. And furthermore, this decreases our RV afterload, and it decreases mortality in ARDS. Now, to go to the second question, which of the following best describes the hemodynamic effects and impacts of VA ECMO on the RV? Excellent. So around 70% of you answered this question correctly. And so the correct answer is C, because as we know, VA ECMO does not increase our RV preload. In fact, it decompresses the right side. So this answer is definitely incorrect. And it also does not decrease the RV afterload, because what VA ECMO does is that it decompresses the right side and bypasses the pulmonary circulation into the arterial return. And so the correct answer is it decreases our RV preload and bypasses our RV after. To go into details on how VA ECMO impacts our RV, it basically reduces our RV preload and it bypasses our RV after. And again, it reverses all the correctable causes. However, the caveat of VA ECMO is that it can potentially increase the LV afterload. And if this was not vented appropriately, it could cause LV distension, which could later promote pulmonary congestion. And so this is just a repetition of what we just said. And basically ARDS with severe RV dysfunction, if we put those patients on VA ECMO, it bypasses the RV and the pulmonary circulation, which offloads the RV, offers systemic circulatory support, and we mentioned the caveat already. So if we want to make a comparison between VV ECMO versus VA ECMO in terms of some important physiological parameters that will help us decide which modality is the best to treat RV dysfunction that is associated with ARDS. So we mentioned that both of them decrease our pulmonary vascular resistance. However, VV ECMO has little to no effect on the systemic circulation or the systemic vascular resistance. However, VA ECMO does increase. And VV ECMO does not have the disadvantage of increasing our LV afterload. However, VA ECMO does. In terms of pulmonary congestion, so VV ECMO offers a better environment because it corrects all the abnormal things that invasive mechanical ventilation can provide to the pulmonary congestion. However, VA ECMO has the advantage of completely bypassing the pulmonary congestion. And if we talk about north-south syndrome versus Harlequin syndrome, VV ECMO does have no contributive factor to that, while VA ECMO can contribute to that. And this will come important in the next cases to discuss. If we talk about MCS options for ARDS and RV dysfunction, we have a single RVAD without oxygenation. We have the use of VV ECMO. We have the use of the venopulmonary arterial ECMO, which the cannulas are generically called the Protect Duos, that were quite common in the ARDS COVID-19 era, but have become less common nowadays. We have the VA ECMO, and we have hybrid configuration that we will discuss shortly. So venopulmonary arterial ECMO, which is the Protect Duo, is basically a single cannula that is inserted most commonly using fluoroscopic guidance. The inlet sits in the right atrium while the outlet sits in the pulmonary artery. And so what it does basically, it drains all the blood from the right atrium and it returns it into the pulmonary artery. This goes into an oxygenator and it is a modality of VV ECMO. And so when we look into this specifically, and when we look into a treatment bundle that was published, including this intervention, it was associated with high survival rate to hospital discharge in patients with ARDS. 80% of those patients survived to hospital to decannulation, and 70% did survive to hospital discharge. However, one of the disadvantages of this cannula is that it has been shown to have some flow problems, and that's why it has become less used nowadays. This is the results of Dr. Asif, which had very excellent results in the COVID-19 era. Now, if we go back to our first case, and this patient, as you all saw earlier, had somewhat borderline COVID-19 improving respiratory status, but has been starting to have increasing RV dysfunction. And he has been showing to have even cardiogenic shock secondary to RV dysfunction, but at the early stages. And to remind you, this was the echo findings of this patient. And so this patient was started on RV rescue therapy with inhaled nitric oxide, IV milrinone, vasopressin, norepinephrine, trying to support the RV. However, all of this failed, and he remained in showing signs of shock with rising lactate and cool peripheries. And so when you diagnose this patient, you have to make sure what is the etiology of the RV dysfunction. Are there any further investigations that this patient requires? For example, to rule out RV ischemia, to rule out PE, and what other management options can be provided for him. And when we talked about all of these management options in terms of mechanical circulatory support, let's see which one of those is more favorable to our patient. So RVAD is not favorable because his lungs still require support and RVAD does not run via an oxygenate. VV ECMO, however, is a suitable MCS modality for this patient. Venopulmonary arterial ECMO, a Project DOO, for example, is also a suitable modality for this patient. VA ECMO, however, is probably not the first thing you would start. And hybrid configuration is definitely not the first thing you'll be starting. And let's see why. So when we continued into this case, this patient was cannulated with femoral right IJ VV ECMO configuration. A CT pulmonary artery prior to that showed no PE, and a coronary angiogram showed normal coronary. So those were two important things to rule out, especially that this patient was above 50 years of age. This patient did quite well. He was decannulated after 14 days, and he was discharged home after a complicated hospital length of stay of 74 days with lots of issues. However, he was successfully discharged and he returned to the clinic in good condition, and he actually walked to the clinic. So if we want to go through this case, why did we select the femoral right IJ configuration? And why did we not start with VA ECMO considered in this patient? Because we already mentioned that when we put patients on VV ECMO, even though they have signs of RV dysfunction, if they are not in extremis situation, if their RV has failed RV rescue interventions, these patients have been shown when you're putting them in VV ECMO that they have chances of decreasing the RV after. And in the same setting, the femoral right IJ configuration helps with the ARDS. So two problems are solved with VV ECMO without the necessity to put those patients into VA ECMO and avoiding all the complications of the arterial cannula of VA ECMO. In terms of take-home messages from this case, ARDS, as we mentioned earlier, can cause severe RV dysfunction. VV ECMO remains the best option provided in the absence of severe circulatory shock because it can treat RV dysfunction and it can treat our ARDS. So the one line that I want you to remember from this case is if we have bad lungs and bad RV, but we still have normal circulation, VV ECMO is still the first option to consider. So before we go into our second case, let's go through some questions. Excellent. So about 50% of you got the answer correct. And so if we summarize this case in brief, this is an ARDS patient where his respiratory parameters are actually getting worse. She is starting to have signs of RV dysfunction that are imminent on her echo and on her pulmonary artery catheter numbers. She is on modest doses of vasopressors, and her kidney functions are still within normal ranges. And so if we summarize this case, it still goes into that this patient has bad lungs, average bad heart, but normal circulation. And as we mentioned, for those three combination, VV ECMO is the correct answer. And so 60% of you answered that correct. Let's go into this case. So this is somewhat of a tricky question and the answers are split. So let's go into this case. So this patient shows the following three things together. Bad lungs because he has bad ARDS with low PF ratio and high plateau pressures and hypercapnia. So this patient has bad lungs. This patient has bad heart because the RV on echo is showing dilated RV, septal shifting, D-shaped LV, etc. And this patient also has signs of advanced circulatory shock. And so this is a three combination: bad lungs, bad heart, and circulatory failure. And so in these cases, VA ECMO is definitely an option. one could make an argument that VV ECMO can be started, and if circulatory shock does not resolve, then converting it to VA or adding an arterial cannula would be of use. However, the one thing that does not help this patient is an RVAD, because an RVAD, again, is a sole assist device without an oxygenator. And if we put this patient only on an RVAD without a blender, without a sweep gas, without FDO2, his bad lungs will not improve. And so the correct answer in this case is an RVAD. So let's go into a second case. So we have a 55-year-old male who is also a case of COVID-19 ARDS. After 3 days of proning neuromuscular blocking agent with rocuronium IV, his PF ratio is still below 70 and his plateau pressures are still high and he's very hypercapnic. And all of a sudden, there's a sudden deterioration in his hemodynamics, just like the case that we mentioned before. His lactate is 7.9, his bicarb is 18, he's showing oligouric AKI, his blood pressure is low, and he's quite tachycardic with monitored ECG strip rhythm showing sinus tachycardia. He's on high doses of vasopressors, so not only norepinephrine and vasopressin at 4 units per hour, however, phenylephrine was also started because of significant hypotension. His peripheries are cold, and he is modeled up to his mid-thigh and his abdomen. His transthoracic echo shows the following. So as we can all appreciate, this patient is in extremis situation. And the diagnosis is actually clear. Again, this is a patient with severe ARDS, with severe RV failure, but also with circulatory shock. So this is a bad 3 combination. When we have a cocktail of bad lungs, bad RV, and circulatory shock, this patient needs to be attended to quite aggressively and quite rapidly. So we know when we have someone with bad lungs that they respond to VV, but if we have a combination of bad RV and circulatory shock, this patient will probably require VA ECMO. But what if this patient has all 3 together? What would be the best modality in terms of treatment? So as we mentioned, VV ECMO in this patient alone is not going to help because we have severe circulatory shock. One could argue that you can start with it, but I would argue against that because this patient already has severe circulatory shock. And so what would be the best next step? Would it be to put this patient on VA ECMO? And then if he doesn't do well, to consider a hybrid configuration, or from the get-go to start this patient on a hybrid configuration of ECMO? So let's look into the advantages and the disadvantages of VV ECMO versus VA versus a hybrid configuration and cross-reference it with our patient. As we know, VV ECMO is good for bad lungs and it's good for RV dysfunction, but it's bad for circulatory shock. However, VA ECMO is okay for bad lungs, it's good for RV dysfunction, and it's good for circulatory shock. The disadvantages that we can get from VA ECMO are north-south syndromes, especially if we have bad lungs and an ejecting heart. And if we remember our patient, he has bad lungs, he has severe RV dysfunction, but from the echo that we saw, and I'll put it back again, he still has preserved LV function. And so with bad lungs and preserved LV function, if we put patients on VA ECMO, we run a high risk of going into Harlequin syndrome or what's called north-south syndrome. And so VA ECMO, again, in those 2 situations where we have bad lungs and an ejecting LV, this will cause high risk of north-south syndrome. On the other hand, if we put those patients on VA ECMO, remember that we need an appropriate venting strategy, because if we don't provide that, the LV could distend further, and this could lead to further pulmonary congestion and pulmonary edema. And so, can this be solved by a hybrid configuration? The answer is yes. So if we put this patient on V-AV ECMO, which is basically drain with a single cannula that drains the vein, and return into a femoral artery and into the right IJ. And we'll look into a picture in a minute. This is good for bad lungs, it's good for bad heart, and it's also good for circulatory support, just like VA ECMO. But it does not have the risk of north-south syndrome. But the disadvantage is hybrid ECMO circuits require specialized care and they're associated with higher complications. So let's look into that in details. So this patient was cannulated with MVA ECMO. And the reason why he was cannulated with FemVA ECMO, because it's not wrong to start with this configuration. And if you face trouble, you can always problem solve and troubleshoot what you go through. And remember, this patient had bad lungs, bad heart, and severe circulatory shock. The echo showed, as we mentioned, preserved but empty LV. And so he did go into the complication, the dreaded complication of north-south syndrome. So this was diagnosed with arterial gases and with NIRS that was put on his scalp that showed that he had hypoxia in his upper body and pulse saturations in his lower body. So what is the next step or the next intervention that could solve this problem? And the answer is a hybrid configuration. So when we started this patient, he was on only FemVA ECMO. However, we tackled this by adding a return cannula in his right IJ. And this solved the complication of north-south syndrome. Now, before we end, and we're going to end within 5 or 10 minutes, let's go into this small quiz. And this is not a quiz that has a poll that you're going to be able to answer, but let's look into these hybrid configurations together and see how can we label them correctly. One of the things that I always tell my learners is that remember that the oxygenator is the dash. Anything before the dash is the drainage cannulas, and anything after the dash is the return cannulas. So look into this picture and try and think, what is this hybrid configuration? So let's look into it together. We have one drainage cannula from the right IJ and one drainage cannula from the right femoral vein. So here we have two drainage cannulas. So we have VV before the oxygenator, which is the dash, and we have one return cannula into the femoral artery. And so here, the correct configuration of this patient is that he's on VV-8. Let's look into this patient. And again, always start when you're confused by putting the dash. The dash is the oxygenator, and whatever drains comes before the oxygenator. So let's look into this case. How many drainage cannulas do we have? So we only have one drainage cannula, which is from the right femoral vein. So this patient starts with only one V before the femoral vein. However, he has two return cannulas. One goes into the right femoral artery, and one here goes into the right IJ. And so this is V-AV ECMO, because we have one cannula going into the right femoral artery and another cannula going into the right IJ. And one could ask, why do we not say it's V-VA ECMO? And the answer is, you can say that as well. The first letter is the first cannula that was placed. So for example, in our patient that we just mentioned, he was put on VA ECMO, and then later a return venous cannula was added to the IJ. So this is what we call it. However, if this was a patient who was an ARDS patient with VV ECMO and then developed circulatory shock and an arterial cannula was added, so this would be V-VA ECMO. So just two more. Let's go into this case again and think about what the right configuration is here. And always start by putting the dash for the oxygenator, and then look into how many drainage cannulas do we have. So we have one drainage cannula from the right IJ. This is 1V. We have another drainage cannula from the right femoral vein, which is another V. And we have another third drainage cannula from the left femoral vein. So he has three drainage cannulas and only one return cannula to the right femoral artery. And so this configuration would be VVV-A ECMO. And finally, on this case, we have the dash over here, which represents the oxygenator. And let's look into how many drainage cannulas do we have. So we have one drainage cannula from the right IJ, one drainage cannula from the left femoral vein. So we have two drainage cannulas, and we have two return cannulas, one in the right femoral artery and one into the right femoral vein. So here we have blood coming back into the right femoral vein and blood going back to the right femoral artery. And so this is going to be VV-VA ECMO. And the reason why I chose to put this at the end of my presentation is because there's a lot of confusion into the configuration. And when a third cannula is added, what is it called and how are we rightly mentioning it? So let's go into our last question before we end our presentation. Okay, so more than 70% got the right answer. However, I got the wrong answer here because I apologize for the oversight. I should not have written VAV ECMO. This should have been VA ECMO because I just mentioned this patient was initially on VV ECMO, and when we convert VV into adding an arterial cannula, what happens is it goes into V-VA ECMO. However, 70% of you got the right answer. And let's talk about this case in brief. So remember, this patient has bad lungs and he's developing bad RV. And on top of that, he's already on VV ECMO. So how can we support this patient? And there's only two ways to support this patient if he fails all conventional therapies. Is number one, to add an arterial cannula, which is the easiest and the most logistically suitable option. Because remember, COVID ARDS or VV ECMO is a longer duration, uses a longer duration of ECMO. However, VA ECMO only averages between 5 to 7 days based on most published literature. So if we convert this patient into VA ECMO and his heart recovers, his lungs might not recover yet. And so he might need prolonged period of VV ECMO. However, if we just add an arterial cannula to this VV ECMO, once the heart recovers, we can just remove that cannula and he's back to VV ECMO and back to being supported for his COVID ARDS. So the correct answer is to convert him to V-VA. And so the take-home messages from this presentation and the main question that we wanted to answer is, if we have a patient with ARDS who develops RV failure, what is the best modality of ECMO to put this patient on? Is it VV or VA? And remember, when we have bad lungs, we always start with VV ECMO. But if we develop bad heart or RV dysfunction on top of bad lungs, VV ECMO is still the configuration to start with. Because as we mentioned, VV ECMO reduces the RV afterload, helps with hypoxia, hypercapnia, acidosis, and most of these bad RVs will improve once these patients are put on VV ECMO. However, if they are on VV ECMO and they develop worsening shock or worsening circulatory shock on VV ECMO, then the best thing to do is to convert them to V-VA. And finally, the bad cocktail of the combination of bad lungs, bad RV or bad heart, and circulatory shock, the best thing to do is to put them on VA ECMO. And if the center that you work in has the capabilities of hybrid configuration, VA plus a return cannula in the IJ would help avoid some complications as mentioned, north, south, etc. And with that, I will conclude my presentation and I will be happy to take questions.
I don't see much of questions. There is one question not about this topic, it's about and groaning. And we will have a full lecture next week about this by Dr. Akram.
So to touch briefly on that, proning with VV ECMO has not been shown to improve outcomes, and being selective with the cases that you do that is key and paramount. And I will leave that for the separate presentation for Dr. Akram.
Okay, so don't have much of a question. I have one question to you. We had a lady was post-operative cabin, and she came on VA ECMO, and later on she had severe RV dysfunction, so we added Protect catheter. And later on, somehow the LV became severely deconditioning, and we end up with severe pulmonary edema. I don't know whether you have experience with such patients where we drained the right side, then suddenly the left side facing a lot of volume coming to it.
So basically, just to summarize your question, you had a post-cardiotomy patient who developed ARDS and was put on VV ECMO using the Protect Dual cannula. And then this patient developed severe LV distension.
Yeah.
I don't have a good answer to that because the Protect Dual should not give us LV distension unless there was another mechanism for which the LV was stunned. The Protect Dual cannula, the one problem whenever we put patients on the Protect Dual cannula is that it does increase the blood flow to the left side of the heart, unproportional to what the RV does. For example, if this patient has weak RV, weak LV, still the amount of blood that leaves that weak LV and reaches that weak LV has a normal ratio. But all of a sudden, a patient comes post-cardiotomy where there might have been a weak RV and a weak LV, even though there was mild dysfunction of both. And all of a sudden, there's 4 liters or 5 liters Protect Dual suddenly arriving to the LV. That LV might have not been able to take that pressure. And that's why it went into the LV distension. And that's why post-cardiotomy, Protect Dual has not been a successful cannula strategy configuration to help with VVEC.
Okay, I thank you so much for such a great presentation. RV is always the little one who's been kept aside. We look for the LV and we care more about the LV. We used to care more about the LV. My generation, at least. Nitric oxide and this nitric oxide business, which I'm not a big believer of, but some of my colleagues still use nitric oxide as a temporary measure. What's your take on nitric oxide plus ECMO plus pulmonary hypertension plus temporary measure to alleviate some degree of pulmonary hypertension in the acute setting of acute RV dysfunction on ECMO? Evidence-based, meta-analysis, anecdotal, your personal preference. I'm not a cardiac intensivist. I'm, an anesthetist, ECMologist, but I'm not pure cardiac intensivist. So I'm not that much exposed to acute RV or post-cardiotomy. I would like to hear from cardiac intensivist on that, please.
That's an excellent question. I have to preface my answer by saying that inhaled nitric oxide or even systemic nitric oxide through the ECMO membrane oxygenator has not been well studied. We know that inhaled nitric oxide does not improve mortality in ARDS patients. However, if we look into the literature and the number of studies that looked into inhaled nitric oxide, we see that we have not necessarily a lack of evidence, but we have a lack of studies. So it's not a lack of benefit, but it's a lack of trials. There isn't a good number of trials, not even a one single trial that looked into both arms with good methodological comparison. To preface the answer, this has not been studied well, and that's why inhaled nitric oxide yet to date does not have a mortality benefit in these cases. However, anecdotally, inhaled nitric oxide and systemic nitric oxide has been used increasingly, especially in centers where you can connect it to the membrane itself. My personal belief is that I use it in multiple conditions. Number one, where I have for sure pulmonary hypertension and someone who's hypoxic, we find that anecdotally these patients, they have improved oxygenation. Number two, I use it as a rescue or as a salvage therapy. So for example, if I'm willing to put this patient on an ECLS, I need something to buy time until this patient is configured and cannulated. I use it as a rescue therapy in that regard. And number three, it has been shown to increase the longevity of the oxygenator length and the lifespan of the oxygenator. And my colleagues, especially in North America, have been using it more and more because the oxygenator lifespan has been increased. And so once you connect it to the membrane oxygenator, that's what's been found. I do not particularly use it for long duration with my patients of VV or VA ECMO. But again, as I mentioned, I use it either at the beginning or for a specific reason.
Lovely. Thank you so much.
Thank you very much, Dr. Kumail. I would like just to add a bit.
In the other,
Hello? Can you hear me?
Yes.
I just would like to add a bit. We have to differentiate between inhaled nitric oxide and the nitric oxide when we connect it to the ECMO circuit. The ECMO circuit, it's more of increasing the longevity, and we have one lecture with the Professor Giles speak about that. But with inhaled, we use it more, like you mentioned, on some rescue until we figure what we are going to do. Almost 2 weeks ago, we used it for a patient who had dysfunction, mix of sickle cell chest syndrome, pulmonary embolism, and we were not able to generate a lot of flow in the ECMO. It was just 1.5, 1.6. We used the inhaled nitric oxide as a rescue until we were able to get more on the ECMO flow. We used it a few times post-operative just to deal with a sort of RV dysfunction for give you some time just until you can fix what's going to happen in this patient.
Excellent. I agree with that comment.
All right. So many thanks for all of our attendees. This was really a great webinar.
I'm sorry to interrupt. I can see a couple of more questions on the chat. I don't know if you want to address them or are we short of time?
No, that's fine.
There's a question. What do you think of Ventavis in RV failure? Do you use PA catheters to measure? So Ventavis or inhaled Flolan or inhaled epoprostenol is again a pulmonary vasodilator. In some of the centers where I used to work, where they did not have inhaled nitric oxide, it was the treatment of choice instead of inhaled nitric oxide. And looking into the numbers per se, and looking into the RV on echo, so using inhaled Ventavis or epoprostenol did not change how the RV looked on echo from anecdotal experience. However, it did improve the pulmonary numbers used if a pulmonary artery catheter was used. And so we found that our mean pulmonary artery catheter numbers dropped by around 10 to 15% after the utilization of Ventavis. However, again, this is anecdotal. This is not a published and peer-reviewed experience. More literature and more studies have to come. And then the final answer is, what about the risk of NO2 toxicity if we connect it to the oxygenator? I'm not a good person to answer this question because in all the centers that I worked, we do not have the capability of running nitric oxide in the membrane. So my answer might be purely theoretical.
All right. Really good presentation. Many thanks for all our colleagues who attended this webinar and stayed with us there in late time. It's almost till 9 o'clock here in Saudi Arabia. Many thanks. And we'll see you next week, inshallah. Thank you very much.
okay. Good night, everyone. Take care. See you. Bye.